Good afternoon, ladies and gentlemen. It is my great honor for me to chair this section, this symposium. First, I'd like to thank Dr. Yan, co-chair of this symposium, who organized this symposium. And secondly, I also like to thank IUFAR to provide this opportunity for us to present this very interesting topic, immunotherapy. These symposiums will have 5 talks, and we will focus on the clinical outcome, resistance, and the challenge in this immunotherapy. Dr. Yan, the first speaker would be Dr. Yan. So allow me to introduce Dr. Yan first. Okay, Dr. Yan was the endowed chair at the City of Hope Comprehensive Cancer Center from 2008 to 2014. Then he returned to Taiwan to serve as the president of the Taipei Medical University from 2011 to 2017. Then he was the chair professor of Research Center of Translation Cancer Medicine in Taipei Medical University from 2017 to 2022. Since 2011 until now, he is the trustee and the board member of Tom Price. Dr. Yan long-term focus on clinical cancer research and translational medicine. He has many valuable experience, not only in the clinical oncology, but also in the translational medicine. He also devoted himself in the research and the development of biotechnology industry. So I think he will give us a very comprehensive and stimulating talk today. So let's welcome Dr. Yan with warmest applause. Dr. Yan, please.
Yeah, thank you. Thank you, Professor Lin, and thanks for joining this afternoon session. We have 5 speakers, and I will start my first talk first. And from this slide, you can see our focus for today is to talk about the clinical manifestation or the challenge from the current immunotherapy. Particularly, I will focus on the CAR T part. And about 10 years ago, and we started using the immunotherapeutics agents such as PD-1, PD-L1 inhibitors, and we start to see lots of the adverse effects. And at the beginning, we are questioning about what is that. And then gradually we know this more likely is a cytokine storm. And the storm is all over the body, and you can see they attack the brain and eye, thyroid, GI, everything. And how to understand the background and how to fully utilize our existing knowledge has become our challenge. However, if you look at the NCCN guideline, and we start to realize that not much we can pick and choose in managing these immune-related clinical problem. Still, the good old steroids still be considered, and the anti-fever prophylaxis antibiotics, that's about it, and not much update. So today's talk, mainly we try to bring up some new things, new thoughts behind this. And this is first figures to talk about the relationship among all these players in immunotherapeutics. And start from the 2010, we start to use the T cell to manipulate it, and then send it back to the patient to challenge our tumor cells. And Dendron is the company lead that this clinical application. And then we have Bristol Myers, ipilimumab, and then pembro, etc., one by one. In 2017, we started have a CAR T, and ever since the CAR T started, and this clinical adverse effect, such as we mentioned about the cytokine release syndrome, become much aggressive and more severe and worsening. And this is just a simple cartoon to talk about the CAR cell itself. The CAR means chimeric, so the chimeric is combine the antigen recognition domain and the T cell activating molecule together. And so this is a SCFV part, and then they can really provide like two functions. One is just like a monoclonal antibody. They have a binding affinity and the binding specificities. And the second, they have a toxicity from the T cell, and they can continue to provide this target-driven toxicity in a very precision way. And to make it a CAR T, they already go to the generation 4, and the changes on the generation from 1 to 4 mainly is changing about the co-stimulator, what kind of co-stimulator we should use. From beginning, the first Novartis drug, they use CD28, and then gradually the several drugs after that using 4-1BB. And the T-cell receptor, they use CD3, and then gradually there's many others also coming up. Yeah, so today's talk, the overview is highlights as below. And first we talk about cytokine release syndrome, and also talk about IL-6 and what a role, and then symptom clinically and how you grade that, treatment option. And then we talk about the CAR T related neurological event, that is talking about the background, how the blood-brain barrier get break down, and what kind of symptom related grading, and how to treatment. And then toward the end, we'll talk about hemophagocytosis and then some other adverse effect. And this slide is pretty much covered the cytokine release storm. You can see once you give it a CAR T and the cytokine release syndrome start immediately, almost can be immediately. And generally speaking, that's on the onset day 2. And then you can continue to see that to last for about like 7 days in average. This is a median. And as for neurological event, you can see a few days later is roughly about day 4, and then continue to last about day 17. And they are related with cytokine storm, and so we give the name the CRS, cytokine release syndrome. And for neurological toxicity, we particularly have a new name called ICANS. That's an immune effect, cell-associated neurological toxicity syndrome. Yeah. So this is a very early beginning. We have all the 3 CAR T start using in marketing and clinical medicine. They're all CD19 related. So when we see traditionally the cytokine release syndrome getting worse than the PD-1, PD-L1 drug, we believe that must be CD19 caused that. However, we see if we look carefully, they are actually different. The first CD19 drugs, and they have they are using the CD28. The Novartis one use 4-1BB as a co-stimulators, and Juno Therapeutics use, however, again is a 4-1BB, but changing the hinge site. So people argue at that time whether this more significant cytokine release syndrome is related to CD19 alone, because these 3 are all CD19. And this is a quick summary about these 3 CD19 driven, as I mentioned, the co-stimulator 28 or BB. They are different, and people sometimes argue that could cause the neurotoxicity more related, or maybe this overall cytokine release syndromes more from the co-stimulator, the 28. But actually, if you look at it carefully, there are not much changes, because based on the classification of the grade, they're using totally different grade. So if you're dealing with a different grade, how you can really put the percentage and do the comparison. And so if you goes by the evidence base and check out the new grading, and we will find out they are pretty much about the same. Yeah, and then we have a question about whether CD19 itself caused that. And CD19 is mainly expressed by most B cell malignancy. So if a CD19 expression is generally restricted to the B or B cell precursor, and we should only see the B cell related toxicity, but it's not. We see the storm, we see the cytokine. It's not just from the B cell induced or releasing. There's much more than that from the CAR T treatment. So we know we are dealing with a more aggressive condition than before. So another question is that if we think these cytokine release storm related with CD19 dominant, and then these two are really the new CAR T. They are targeted on the B cell mature B cell membrane antigen, and they focus on multiple myeloma. So they are different. They are not leukemia. The B cell leukemia, they are not the lymphoma. They are multiple myeloma, and then they have a totally not CD19. We still see lots of the cytokine release syndrome. So we know this must relate with the CAR T rather than just antigen itself. And also at the beginning, we think that must be because we target on the lymphocyte and they lysis, and then they cause the cytokine. The reality is that we see more than that. We see more macrophages activity. We see dendritic to be activated. We of course see the lymphocyte, and we see B, and we also see CAR T itself. And some cytokine released come from lymphocyte-driven, but also non-lymphocyte-driven as well. So we again believe this is not just CD19. This is not just the co-stimulator. It's not as the routinely we believe we know about cytokine. Actually, things are much more complicated. All these cells all play some role in this cytokine release syndrome. And first, if we consider the CAR T start to killing the tumor cells, and then they secrete the cytokine, and then the next step, immediately the tumor cell gets damaged. The damage associated molecular pattern we call DAMPs, D-A-M-P-S, has been identified in more than one. It's a whole spectrum. And these things is a very good trigger factors to induce macrophages. Actually, macrophages play much more role in this cytokine release syndrome than the T, CAR T, and the B cells. And this macrophages, they'll get activated by the DAMPs, and the T cell cytokine start to release the IL-1, IL-6. When IL-1, IL-6 come up, and then they are inflammatory cytokines. And therefore, they further increase the T cell activation, and they become a systemic effect. In the meantime, there is interferon gamma, GM-CSF, and the TNF also release it and continue to trigger the macrophages. So there's more than one cells, there's multiple cells, and there's more than one or few cytokine, there's multiple cytokine, and not just one epsil. This is a malicious circle continue running after the CAR T given. So this is not a small things or not a simple, easy mechanism behind. And in all of the cytokines, IL-6 probably played the major systemic mediator in the pathogenesis of the cytokine release storm. And the first is the active phase, acute phase protein. They all release the CRP, complements, and the fibrinogen, ferritin, etc. And then the more worsening step is they are leaking out the endothelia, and then they cause the vascular leaking, and after that, the volume overloading, and then electrolyte imbalance, hypoxia getting started, and then hypotension as well. So the whole cardiovascular compromise, that including the kidney. And once the monocyte get induced, and then they start to release thrombin, and that caused the further hypercoagulation status and the DIC, and microangiopathy, and all the multiple organs start getting failure step by step, and much more. And if we look at these cytokines itself, and then we see several cytokines are related with the severe cytokines release syndrome much more. That is all I listed here. But I would say this IL-1 and IL-6 probably play majority role, and the GM-CSF also, interferon gamma, alpha as well. And there's some cytokine occasionally being reported, but not significant or not directly associated with aggressive cytokine release syndrome. And there's a chemokine as well, but it play lesser role in compared to the cytokine, and the many other growth factor also related, such as the von Willebrand factor, such as the VEGFR as well. But with all of that, the worsening things is come up from the tumor growth, tumor necrotic factor alpha and interferon gamma become accumulated. Once they accumulated, they already get into the cytokine storm, and this is a malicious circle, and eventually lead to the multi-organs failure. Yeah, but this is not just CAR-T cause that. Bacteria, sepsis can cause that, and virus can cause that, and many other things can trigger that. So it's not specific for CAR-T. But apparently, CAR-T attracted too many cells and work together and build up this storm. So this perfect storm, stronger, much strongly related with the CAR-T treatment as compared to other treatment. But if you compare to the severe virus syndrome, severe sepsis, they are pretty much all the same. And the same in the symptom mainly. They fever, they drop the pressure, the heart compensatory go high, and with the tachycardia, and further induce AFib, and the cardiac arrest, eventually kidney failure, and from capillary leaching syndrome, heart, lung, and the kidney failure one by one. And you will see hemophagocytosis. That means your macrophages start to eat your red blood cell, etc., and the lymphohistiocytosis as well. Yeah, these are all really put together. But it's very hard to grade this, because the grading start at the beginning from the Lee criteria, and they start to looking at fever or not fever, life-threatened or not. And then they consider, how about, do you use or not use the pressor? If you need a pressor, one pressor or more than one pressor. And then you look at the oxygen level, greater than 40% or less than 40%. Do you need a 6 liter per minute oxygen supplement or not? These criteria have been used for a while, but then everybody feels it's complicated and hard to accept it. So, and then the criteria have been changed a little bit more under the American Society of the cell therapy. And they use the symptom, and they use the fever, they use the blood pressure, and they use the oxygen level. They base on the pressure, with or without pressure use, or multiple pressure use, with or without oxygen use. You give the nasal cannula oxygen delivery, or you need the CPAP, et cetera, et cetera. So that's just from clinically, we try to make it easier to grade it easier. But if you grade it right, and then you can retrospectively look at all these CAR T, whether any CAR T really related to the stronger side effect, and then you go to improve from there. So this is why the grading is critical, especially the grading become really the outcome-based and evidence-based. So ever since we used the fever, pressure, and hypoxia, and this make it relatively easier. This is using in a clinical. But this is still not perfect, because how come you can say, oh, this patient is using 40% oxygen, and then they maybe use 60% oxygen 5 minutes ago? Or how long you use 6 liter per minute oxygen the supplement? They can be transient. The pulmonologist know this is not a time point issue. This is the whole spectrum issue. This is a whole trending issue. So sometimes we still feel it's really hard to determine. And that is all about the symptom, but how about sign? There's no sign can help us to determine, and this patient already get into cytokine release syndrome or storm, because all the lab tests, all the signs are the same as sepsis. All these patients easily get the sepsis anyway. CRP, ferritin, and fibrinogen. These 3 are commonly being brought up, but still, at this moment, there's no definitive answer to help us to determine that. And worse than that is, clinically, as a physician I sometimes see the patient, we don't know which is which. We think this patient got cytokine release syndrome, but that could be just sepsis. That could be the tumor get destroyed and the tumor lysis syndrome. Heart failure can come from many other things. Volume overload is very common in clinical setting. Blood clot, another common thing, DVT, ARDS. So how you want to differentiate this CRS from other related with the underlying disease listed over here, it's a very challenging. You need to be very keen, very alert, and make sure you know the patient well from the beginning you treat it, and then you can do the quickly comparison. Or you need to do lots of the tests to make sure what is the baseline before you start to treat it. And how to exactly treat anything to CRS? There's really no specific. And most of the time, we give the supportive care if that's the low grade. What low grade means, don't need much oxygen and the low grade fever, etc. And we treat it with the supportive care. But very important medication we are using nowadays is an anti-IL-6 receptor antibody, tocilizumab. And tocilizumab has been proved ever since the first CAR T get approval in 2017, and then we started using that. And this drug will not interfere CAR T itself. So this is a very helpful drug, but very expensive is another concern. And also, tocilizumab, that is the anti-IL-6 receptor antibody. So if you block the receptor, sometimes temporarily you push up the IL-6 level in the blood. So once this pushed up, sometimes can cause the worsening temporarily, but that could also be a trouble to the clinical setting. Another clinical trial using TNF-alpha as well, and many other, all been considered at this moment. And to manage the CAR-T-related the CRS, we usually don't use the steroid at beginning. We prefer to hold it off until the patient become much more severe CRS. Because if you go give the steroid fast too early, you really cause the immunocompromise, then worsening your clinical setup, such as get infections as well. And so we usually reserve the steroid for the tocilizumab refractory CRS, so we give it later. Another drug is an anti-IL-6 antibody, and cetuximab. And this drug is an IL-6 antibody. It's not IL-6 receptor antibody. Yeah, the antibody is directly attack the IL-6 in the blood in our body. And this drug has some good effect, but the problem is sometimes you need to increase the dose because overwhelm the IL-6. Once you start to giving the higher dose of cetuximab, you start to see tarry stool, blurred vision. You start lots of the chest tightness, etc. That can even worse your clinical judgment. So this is an issue whether we should reserve that until later. Yeah, and anakinra, that is an IL-1 receptor antagonist. We try not to use that since anakinra hasn't been approved for severe CRS yet. So that's just in a clinical trial. And many other drug has been testing or evaluating under clinical trial setting, that's including anti-TNF and anti-GM-CSF and JK STAT inhibitor and the kinase inhibitor ibrutinib. And ibrutinib is very important and very interesting that might change the future clinical paradigm. That's because first, that's oral drug and relatively easy to give it. And second, this is supposed to block the Burton tyrosine kinase BTK. But then further study published by several the PI and suggest that actually ibrutinib has multiple functions. They can enhance the anti-lymphoma activity. That is good. And then they can reduce immunosuppression. So they are not going to see the overly suppressed. And further, they can direct the effect on the T cell function. So this has become a possibility. When we give the CAR T, in the meantime, we give ibrutinib. What kind of dosage? What kind of timing? Should we give it right away? That still needed a little bit more time to understand and find out from the clinical trials. But it's looked like that could be a way. And I used this slide before, and I just want to bring your attention back and talking about the neurological side effect. And neurological side effects start on day 4 roughly. There's a median onset, and then duration is 17 days. So it's relatively, we say, it's 2 weeks of time. So usually we will not see the neurological symptom immediately after CAR T. That's because this comes from blood-brain barrier breakdown. That takes a little bit more time, so a few days later than the CRS. But it's still part of the CRS per se. And we believe at least 2 things are very important in this neurological toxicity. One is IL-1. That might be the first cytokine increase from publication, all shows similar results. IL-1, then immediately IL-6, and then induce the monocyte and attract the macrophages and active lymphocyte, and then the interferon and IL-6 start to break down the BBB. And there's many other cells also get involved. And the other hand, we have angiopoietin-2, which is very important to play the role in the breakdown BBB, because we all know there's angiopoietin-1, which is supposed to keep this endothelial BBB intact. but angiopoietin 2 is just to destroy it. So here, the ratio is really matter. The angiopoietin 2 become higher than angiopoietin 1 and break this balance and ratio. And as a result, the damage of the endothelium of the BBB start to kick it in. And then further, interferon gamma, IL-6, and start to build it in. That caused the whole catastrophe started. But for some reason, and we see CD19 related CAR T has shown much more neurological toxicity than others. So further studies suggest that this CD19 probably trigger the macrophages and get involved into this breakdown. And this breakdown also possibly related with the VEGF and the von Willebrand factor. And not just macrophages. Actually, microglia is become much more important in playing this role about breaking down this BBB, same as this dendritic cells as well. And this is ongoing, and this is new, and we are seeing this part in publication more and more. Eventually, we will determine whether CD19 really played this unique role and how to improve from there. And symptom-wise, it's quite straightforward. You will see encephalopathy, and you have a dizzy, tremor, delirium, all the common things. But once you see the seizure on the patient, you start to worry because that is much more severe, and that usually means there is more other pathology ongoing into the brain, parenchyma itself, that such as cerebral edema, etc. But how to grade it, how to determine that? We usually use this a very helpful the score, the point tool, and you follow orientation and check the patients about age, year, time, and that's orientation, check it up, and the naming, check it up, and you put the 3 objects like a baseball garden, etc. And then importance of following commands, and you show 2 fingers and touch the nose, etc. And writing. And for example, the writing show up here, and the patient start March 28, he can write pretty well. I love my family, and then starts sketchy, and just like a doctor's writing now. Yeah, and then here it's just not sure what's going on, and then you could become that. That is only 1 day. So this is the score tool. We determine this patient is downhill. And if that's a grade 3, and that's usually score is low, they cannot pass the name, orientation, etc. And usually they will have a seizure kick in, and the motor nerve also start to show worsening, such like a tremor, hemiparesis, and paraplegia, etc., etc. So this is a clinical grading to guide us, help us to determine how severe our patient get the problem. And the treatment is very, very important. It's reversible. The neurotox is reversible. BBB will be healed by itself. And so very important is we make sure we have a neuro checkup before as a baseline, and then can do comparison, and comprehensive neuro exam is critical. And then we use the similar drugs, the tocilizumab, just like we treat other multi-organ attacked by the CRS. But usually this is not very concrete to say, but usually if the patient does not have a general CRS but has a neuro itself, it did not work very well by using tocilizumab, because these antibodies really hard to penetrate the BBB. They are poorly. That's why the effect is not good. Another is you you probably have to be very sensitive about you block the receptor and you increase serum IL-6. That can cause a problem. Steroids should be given earlier if you have neurotoxicity shown. Now, this is not the same as the whole body, the cytokine storm. Important is communication, because a patient can deteriorate in few hours, and that is reversible. So you have to give the support and communicate with family to make sure they understand almost all were reversible. So they got to be patient and not to change the treatment plan. So this is just about the neurotoxicity. And then now the third common manifestation is a hemophagocytosis. The hemophagocytosis is relatively old, but that's relatively new. The new because we put this CAR, hemophagocytosis, lymphohistiocytosis. We know the HLH has a de novo. HLH has genetic type. But here we are talking about it's a CAR-T related. They usually come late. You can see this CAR-T related HLH is about day 18. The day 18, which already the CSR, the cytokine storm is passed and neuro has been recovery, but suddenly the IL-6 and other cytokines pick it up, and that causes immediately liver function go high, ferritin, the CRP all go up, and that is something you should think about it. Under the CAR-T treatment that could induce the HLH itself. From beginning, we believe HLH is a variant from CRS. That's because some data suggests if you don't see CRS, you don't see the HLH. Yeah, but reality is it's not true. But ever since we started using CD22, we see totally different landscape. CD19 showed this result, but CD22 the CAR-T has shown much more the HLH. So this looks like it's a different mechanism, but the presentation clinically is very similar as the HLH from the de novo from the genetics condition. And this is very unique. By far, we don't know exactly it's true or not true. First, we know if you dosing CAR-T too much, and you will see more chance in developing HLH. So because when we get the CAR-T, the cell is a range, and the range, you may be happy you have a 10 to 9, but it may not be good, okay? 10 to 7 maybe is better, yeah. So body weight, patient's condition, tumor loading, and the dosing. Now it's a quick under calculation very critically, and the bioinformatician is working on that. And another is a secondary expansion of CAR-T. Because you give the CAR-T, after several days, the CAR-T should go down, but they are not. They are continue expand. We call the secondary expansion. And this secondary expansion cause the further macrophages go higher in number and activate the lymphocyte go higher and persist. Because they are persist, the NK cells supposed to kick in to eat it, to balance it out, but NK start in a very low number, and then that make it a perfect storm to make the macrophage-driven, the activated lymphocyte-driven HLH. Yeah. So the failure of the immune response contraction is remain unknown. Why some people suddenly present that, allow the immune response, the failure of contraction, and then allow second expansion and low number of NK. And the study shows some patient under the bone marrow transplant before the CAR T treatment may run in some problem like this HLH, but we don't exactly sure yet. And HLH has a long name. I don't want to repeat it, but important is in the future, the name might be changed to just call macrophage activation syndrome. Macrophage activation syndrome, MAS. That's easier because they were not confused with the genetics the subtype of the HLH or other disease or condition related. Because by far more likely is the macrophage activate. It's the real problem to cause that. This is high mortality. Even though they start late, like day 18, and you think the CAR T already kicking well, but then suddenly you see patients start a fever again, and then the liver function go high, and multi-organs start to shut down, and these are high mortality. This all the symptoms just like a cytokine storm come back. But reality is that you need to do the bone marrow. You have to go by bone marrow because ferritin probably not going to help you much. Other liver functions not help you much. There's nothing helpful because a lot of symptoms and signs overlapping too much from the previous cytokine storm or underlying problem. Only the bone marrow can help you. From the several studies already summarized in this slide show, the only bone marrow can help you to determine macrophages activation syndrome. And that is more precise than any symptom, sign, fibronectin, ferritin, or whatever. And this is just a typical the hemophagocytosis, the macrophages, the chewing your red blood cells, and then you use a stain CD68 to confirm. And if you see that from bone marrow, and then that is the diagnosis for HLH. And be careful, this patient needs strong support because they have a high mortality. The treatment is a little bit different. And we use the IL-6 receptor treatment, tocilizumab, or the anti-IL-6 antibody, and cetuximab, and we give the steroid very early. Besides that, we also give etoposide. Etoposide VP16, which is an old drug, because we know they can kill the activated lymphocyte. So that's why we use the etoposide, and we also can use the cyclosporine, and pretty much the same IVIG, just like pretty much like we treat post bone marrow transplant and that kind of HLH, and much more aggressively though. Yeah, so this is just the summary, the HLH, the follow the CAR T, the trending. And this is the day 14, the IL-6 pick it up. And the other IL-15, macrophage, all pick it up here. And the symptoms start to have a fever, all come up on the day 18. And then you give all the treatment as you can. And you give IL-6, the receptor antibody. And then you start to do the bone marrow to confirm MAS. And then you start to treat the steroid, dexamethasone earlier, faster. And etoposide is a very, very important drug. And anakinra, you give that. Anakinra is not approved for CRS. However, they proved it for HLH. So anakinra is a unique drug, IL-1 receptor antagonist, only approved for HLH. Another is anti-interferon gamma that has been proved in the history, long history, for primary HLH that all can be used. And then the etoposide, that is the one which is used in the old chemotherapy era, but now become very important to deplete this hyperreactive lymphocyte. And this is other adverse effect. such as cytopenia and infectious. I don't need to mention too much. And CAR T, especially CD19, is primarily targeted on the B cell, precursor B. So the B cell aplasia, hypoglobulinemia is also can be found. And GVHD is very important because at this moment we use autologous CAR T, so you don't see much GVHD. However, in the future, if you use the allogeneic CAR T, and you will start to see GVHD. Another thing is we already seen, especially at City Hope, the lots of bone marrow transplant receiver, and after that they start to use CAR T, they increase GVHD. So you need to protect it the earlier. So lastly, before we finish, how to prevent it? What kind of patient is high risk for all of these? Then usually, if early onset means bad, and a high dose, a high disease tumor burden is also bad. And from statistic identify fludarabine-based conditioning cause the lymphopenia longer, it's bad. And high dose CAR T is not good. So you have to be alert. And if it's thrombocytopenia high, or with the CAR T without selection CD8, these are all not unfavored. Ferritin maybe is the only sign continually being shown on the publication, which is better than fibrinogen, better than other. So what's the future? If we are going to continue use CAR T, and we will try to avoid that, so people start to think about putting some suicide gene to make it off and on, or you induce the caspase-9 to chop it out by enzyme or by others. And these are all under experiment. Another is, how about forget about CAR T? We use the NK or gamma delta T, because the NK, presumably there's no GVHD, and gamma delta T, no GVHD, which is good. Yeah, but the NK, we think that can cross the HLA, but then sometimes you still see the minor symptom from that. Gamma delta T maybe is the one potential in the future, but the number, cell number, still is a big challenge, and we need expansion, we need selection, and we have an expert here, sit here, you can ask her. Yeah, so this is a reference I use, and you can take a look. Yeah, and I wish this is helpful for you about understanding these cytokine storm, neurological toxicity, and HLH related with CAR T, and actually occasionally you will also see in just PD-1, PD-L1. Thanks for your attention.
Thanks, Dr. Yan's wonderful and stimulating talk about the CAR T consequence. Okay, so now is the Q&A.
Hello, thank you for the interesting talk. Bas Zagalai from Western University, Canada. So my question is, are there any identified factors that contribute to the occurrence of secondary expansion of CAR T?
Well, some people use the PD-1 as a marker, yeah, to see the exhaustion of the T cells. So they also try to apply that to see if the PD-1 persists, yeah, and then whether they play some role. But be honest, there's no solid data yet. And people all start to looking at, this is very critical, yeah, at this moment, yeah. Yeah.
Again, thanks for that terrific overview. Question, is there any evidence to suggest that the intensity of, say, CRS or the side effects may correlate with the response to the CAR T therapy?
Yeah, people try to think more aggressive cytokine storm maybe lead to a better outcome from the CAR T. Answer is no. By far, there's 6 different CAR T regimen right now. At this moment, none of them show that yet. Yeah, but it's still not enough numbers since this is still relatively new. Yeah. Okay. Thank you. So now I'd like to introduce the next speaker, Dr. Kwang-Yu Chang. Yeah, Dr. Cheng is currently associate professor and medical oncologist at the College of Medicine, National Cheng University, Tainan, Taiwan. Dr. Chen received the MD in 2002 from Kaohsiung Medical University, and then followed the medical oncology fellowship training at the National Health and Research Institute, Taiwan, which is equivalent to NIH in the United States. After that, he went to Johns Hopkins to study the immuno-oncology from 2014 to 2016 as a postdoctoral fellow. Once he got back to Taiwan, he started to lead the immuno-oncology at the NHRI, and his focus is in the microenvironment, in tumor, and how to apply immunotherapy and the old traditional chemotherapy in combination and related with mechanism. Yeah, now welcome, Dr. Chen.
Thank you, Dr. Yan, for your beautiful introduction. And I want to thank the organizer of WCP 2023 for this opportunity for me to have a talk here. And of course, also I want to congratulate the organizer because of this beautiful conference. So all of us have the beautiful time here, and much of the thank with everybody to come over here. So today I'm gonna give a talk with my title, Targeting Tumor Microenvironmental Factors to Overcome Obstacles that Block the Effect of Immune Checkpoint Therapies. So first of all, I would like to have my relevant financial disclosures, and because actually I almost have nothing to disclose except of the following slide. I will present a Polaris Pharmaceuticals sponsored clinical trial, and because of the clinical trial have been taken place in our institute, so I have the opportunity to have the speakers fee from them and to present for them, but not for this time. So this is my first slide, and I'm at being an oncologist. I guess I am very fortunate to have been experiencing the treatment development during these few decades, and comparing to the several decades ago, well, we have very desperate disease over oncology disease. Today, we have a lot of weapons over there, including chemotherapy and target therapy and radiotherapy. And of course, later we have immunotherapy that have been developed. And speaking about immunotherapy, I would say this is a very big breakthrough because we have found out that the translation of the tumor immunity into the clinical practice from the immunotherapies, especially with the development of immune checkpoint inhibitor, and we will call it immune checkpoint therapies here. So this actually highlights the PD-1 and PD-L1, and which almost occurred in a lot of type of tumors, but there's still some limitation of this specific treatment. For example, in some of the cancer types, we found that there's a low sensitivity of the ICTs. And moreover, actually, the efficacy differs not only in the different cancer types, but also between the individuals. So what we have learned is that the tumor cell itself can determine the susceptibility of the IgT. But recently, we also found out that the microenvironment plays a critical role in determining the susceptibility as well. Since there's a lot of factors in tumor microenvironment, I think we will focus on 2 factors, including one on nutrition. And in this case, we will talk about arginine, and the other we will focus on tumor cell impact to the immunity, and we will focus on cathepsin and its effect on the tumor secreting factors. So first of all, ADI-PEG20, which is also known as pegylated arginine deaminase, it is able to deplete arginine in the tumor microenvironment, and originally it is designed to kill the cells, the tumor cells, which lack the ability to transfer the citrulline into arginine, because some of them lack ASS1 expression. So with the experience of this experimental drug, we noticed that in some cancers they had more T-cell infiltration while using ADI-PEG20. So we have the rationale of that the depleted arginine might appeal the T-cell infiltration into the tumor. And so we have a hypothesis that using the ADI-PEG20 can appeal more T-cell infiltration. And then we can have additive effect on pembrolizumab, which is anti-PD-1 antibodies. So for this purpose, we talked about the conducting a clinical trial with the pharmaceutical company. And then finally, we have the early phase clinical trial conducted in our institute. And this early phase clinical trial was actually composed of 2 stages. One is the dose escalation cohort, and the other is the MTD cohort. In the first stage, we will determine the base dose of ADI-PEG20 plus and the pembrolizumab. And following the determination of the base combination dose, we will recruit more patients to learn the effect of ADI-PEG20 on the immunity. So the primary objective is actually the safety and tolerability, and the secondary objective is the other stuff we really concern from the clinical view, such as survival and the response rate, and of course how ADI-PEG20 can have the effect on the immunity. So the manner we administrate the study drug is actually ADI-PEG20 in weekly manner, and the pembrolizumab in 3-week manner. So this is the result. So first of all, we're going to go through the demography. Totally, we recruited 25 cases, and their ages are actually, the median ages are actually 54, and then we have a little bit imbalance in the gender with predominant of male cases. And this is probably because of the esophageal squamous cell carcinoma. There's more patients with this kind of specific disease recruited to our clinical study. And the other, for most of the people recruited to our study, they're actually having very advanced diseases, including a lot of metastatic sites. And then they have been receiving multiple chemotherapy, and including prior radiotherapy. So the most important thing we concern is the toxicity, and this is the list of the toxicity profiles. And generally, I guess the grade 3, grade 4 toxicity is not that much. except in the field of leukopenia and neutropenia, we can find more common leukopenia and neutropenia occurred in our clinical trials. However, I would say that besides of these hematologic AEs, for the other AEs, generally, I think it's not that much. But we put special focus on this specific hematology AEs and find out that it looks very severe, but actually, I guess it is really manageable and treatable. Especially, we found out that the application of growth factors can reverse this problem in a very short time. The only problem here is that we found out that there's a little bit interruption in the ADR-PEG20, and but mostly for only one time or two times. But in one case, we found a longer interruption of ADR-PEG20 and a permanent withdrawal of pembrolizumab. But for this problem, it's actually not because of neutropenia, but actually it is because of the grade 3 hepatitis. And generally, these neutropenic events are manageable, but there are 3 patients that developed neutropenic fevers, and but fortunately we used antibiotics with a short-term treatment, and all of the fevers subsided. So I would say that the toxicity is kind of feasible. And for the response rate, the general response rate is 26.1%, and we found there's no response in cohort 2, probably because there's a little sample size. And unfortunately, we don't have the complete response, but with the maximal tumor shrinkage of more than 80%. But we also found out that the people who experience response actually can last for more than 3 or 4 months. So this response actually can translate into the survival, the overall survival, and they have really good correlation between the progression-free survival and overall survival in this swimming plot. So finally, we're just interested in how the ADR-PEG20 can affect the immunity. So in the second stage cohort, actually some of the patients had the post-treatment biopsy, and we can find out that unlike ASS1, which is very varied in pre-treatment and post-treatment, we have the CD3 expression generally increased in the post-treatment, and but unfortunately not in the PD-L1. But this also suggested that with the ADR-PEG20, T-cell infiltration can be enhanced. I guess the major challenge is actually not the T-cell infiltration, but it's because that ADR-PEG20 was made of biological agents, so there's inevitably development of anti-ADR-PEG20 antibodies, and which to the plateau at 3 or 4 months after treatment. And this could result in the restoration of arginine in the blood level, but even in the peak of the restoration of arginine, they never return to the baseline level. However, we found out that the duration of arginine suppression is discordant to the the duration of response. For example, in one patient, B007, who had mucosal melanoma, he had the very short arginine suppression for only 4 weeks, but he had the very long response rate for more than 10 months. So I would say that this is the first clinical report on the safety and the tolerability of ADR-PEG20 combined with ICTs. And we have defined the safety doses and profiles for the combination. Our study also suggested ADR-PEG20 to enhance T-cell infiltration and benefit ICT effect in selected patients. However, we noticed that arginine is utilized by the immunity in multiple manners. So maybe our use of the ADI-PEG20 in such cases is not the best way to optimize the immunity. So more investigations are ongoing in terms of making strategies to enhance the anti-tumor immunity. And for example, in our collaborators lab, we have ADI-PEG20 plus arginine inhibitors, and they have a good result, which was published in 2023 American Journal Cancer Research. So I guess we will move forward to the cathepsin S, which I guess is a tumor factor that potentially mediates the immunity. So CDSS is a cysteine protease that can promote antigen presenting of CD4 T cell and macrophage, which we already know for quite a while. And 3 years ago in cancer cell, there's a very important finding that CDSS is actually in large B-cell lymphoma actually can mediate CD8 positive T cells by altering the MHC expression. So we are very interested in this topic because in our collaborators lab, they already developed a very specific CDSS inhibitor named as RJW58. And then they also have some data showing that using the RJW58 in B6 mouse, they found out that in the serum, they have the altered interleukin profile, which includes interleukin-7 that is interested in from our view. Why is it interesting? Because IL-7 actually can enhance T cell activation and infiltration. So we made a hypothesis that the cathepsin S in the tumor cells actually inhibited its secretion of interleukin-7 and to inhibit to making the microenvironment turning into a protumor environment. So by using some method to inhibit the tumor CTSS, it is possible to restore IL-7 and enhance the infiltration of T cell into the tumor cell, into the tumor tissue. And this could be helpful for the immune checkpoint or the other immunotherapies. So we have some studies result from our lab and was actually shown in the AACR 2023 by one of my by my postdoc fellow called Zhang Yongjie. And actually, he made the studies by approaching the clinical samples and find out that negative correlation between CDSS and IL-7 or CD8. So we used the head and cancer cell as our model and find out in the clinical sample, the higher stage it is, then the higher we found the CDSS, but the lower of IL-7 and CD8 expression. And next, we use the tumor cells as our model and found out that in the in vitro study, by knocking down CDSS, we found out the higher expression of IL-7, and vice versa. By overexpression of CDSS, we found out the regulation of IL-7. And because cathepsin S is actually and protease, so we anticipate the regulation is actually the post-translational regulatory mechanism. And we found out that by using the IL-7 fluorescent as a marker, we found out in the fluorescent microscope that knocking down cathepsin S can enhance the enhance IL-7 vesicle in the B panel B. So it also has some relation with lysosome, and find out that there's the overlap between lysosome, which is represented as LAMP1 as the biomarker with IL-7. And by using SI-CTSS, we found less expression of lysosome, not only in immunofluorescent microscope, but also in the Western blot. and vice versa. When we overexpress GDSS, there's the overexpression of LAMP1, which suggested the relationship between GDSS and lysosome. So finally, we use RJW58 and find out the compound can actually downregulate the activity of GTSS, and then upregulate IL-7 expression and downregulate LAMP1. So I guess this is the final slide showing that GTSS knockdown can reactivate T cells, and we use the tumor cell condition medium to activate T cell, and the tumor cells was pretreated with SI-GDSS or interleukin-7 recombinant protein. And both of the treatment can enhance the activation of T cell. But if we co-treat it with anti-IL-7 antibodies, the stimulation would be alleviated. So this can express a relationship between GDSS and T cell were mediated by IL-7. And finally, we use the mouse model and find out that by feeding RJW58, the tumor cells can be inhibited, following by enhancement of CD8 T cell, both in flow and the IHC staining. So we have the conclusion here that the GTSS can potentially enhance the inhibition of GTSS can potentially enhance the anti-tumor immunity by activating IL-7. But even though we observe this phenomena, we still cannot tell you the mechanism so far. So now in our lab, we are doing our best to find the mechanism of how GDSS regulate IL-7 transportation. So the final conclusion here is that multiple strategies have actually already been developed to achieve a synergistic effect with ICTs. But I guess sculpturing for the pro-immune microenvironment can potentially enhance the anti-tumor immunity and have the advantage on that these strategies probably can benefit not only ICTs, but also the experimental immunotherapies such as CAR immunocytes, tumor vaccines, biotherapies, and so on. So this is my last slide. I want to make an acknowledgement because of I need to thank some of my fellow colleagues, including Dr. Li-Dong Cheng and Dr. Junyan Zhang, because these two are my former director, and without their support, we would not have the clinical trial and also the GDSS study. And also, I would like to thank my lab members, including the postdoc I have mentioned, Dr. Yongjie Zhang, and then all of the investigators that have participated in the clinical trials, including both from our institute and National Cheng University. And finally, the sponsorship from Polaris and the technical support from MD Anderson Cancer Center. So thank you very much for your listening, and hope everybody can enjoy the rest of the conference. Thank you.
Yeah, thank you, Dr. Chen. Yeah, let's take some questions from the floor. Yeah.
Thank you, Dr. Chen, for your talk. And I'm still wondering about the second part of your talk regarding the cathepsin S. Since you mentioned that it is a secretion protein, but in your story, it looks like that is the intracellular cytosolic one to downregulate the IL-17 expression or secretion, right?
That's right, IL-7.
Okay, so for the IL-17 secretion, I also have a question regarding the lysosome-mediated secretion. So have you used the lysosome inhibitor to confirm this really mediates through the lysosome mediate unconventional secretion.
Yes. We have used bufferomycin. The data haven't been shown here, but yes, with bufferomycin, the secretion of IL-7 can be restored.
So how about the role of autophagy? Is it involved in IL-7 secretion?
So far, we haven't go through the autophagy. We just go through the lysosome.
Okay, thank you.
Okay, any further question? Yeah, Dr. Cheng.
So if IL-7 plays a key role, why not just use IL-7 directly as opposed to the cathepsin S lysosomal pathway, which may be a little bit more complicated?
There is actually IL-7 developing in the clinical trial, but I guess the problem of these cytokines, they have a lot of adverse effect. So we try to find the alternative approach to inhibit the cytokine, and this is why we use RJW58.
Question?
Hi, Dr. Cheng, very nice work. And have you ever measured the arginine concentration in the tumor in the first part of work? Do you think that is the effect on the immune cell or the tumor cell, and to mediate the immunity?
You mean that if the arginine?
Yes, in a clinical trial, have you ever measured the arginine concentration within the tumor tissue?
No, not in the tumor. But we try to look over the ASS1 in tumor. And in this clinical trial, we didn't really limit, we didn't really make ASS1 as the exclusion criteria. So no matter how the tumor, if the tumor can utilize arginine or not, the cases can be recruited to our clinical trial.
Okay. Do you think the arginine could, showing effect on the PBMC all in the tumor, all the immune cell within the tumor? Do you think which is more important for this arginine?
Yes. So okay, I would say that well, I would say that sorry, this one. Okay. So I would say that probably some of the tumor can be susceptible to ADI-PEG20. However, we found that in this slide, the arginine suppression actually, in some of the cases, was very short, and this is why I show this slide. I took the example of B007 because for this case, the arginine suppression is only 4 weeks, but the tumor response lasted for 10 months. So that's why I feel that probably there's the arginine deaminase, the effect of the arginine deaminase is not only through the tumor, but probably for the other factors, such as in these cases, I would say immunity.
Okay. Thank you very much.
Any further question? If not, thanks, Dr. Cheng. Thank you. Yeah. Our next speaker is Dr. Oliver Burk. He's going to give a talk about the antagonists of PXR receptors in colon cancer. Dr. Burk is from the PI from Dr. Margarete Fischer-Bosch-Institute of Clinical Pharmacology, Germany. Yeah, please, Dr. Burk.
Thank you, Dr. Yan, for your kind invitation. And I'm happy that I have the opportunity to present our work here in this session, even if this is a little bit out of the topic. So we shift a little bit gear now to look for how regulation or modulation of a nuclear receptor can help revert resistance to chemotherapeutics in colorectal cancer cells. This is actually a proof of concept study, in vitro study, to see whether this is really feasible. So to begin, I want to give you a brief introduction to the pregnane receptor, because I assume that you will not be very familiar with that. And it's a member of the nuclear receptor family with the official gene nomenclature name NR1I2, mainly expressed in liver and intestine, and for be functional, it has to be heterodimers with RXR. It's mainly active as xenobiotics, including many drugs, especially in that context, chemotherapeutic drugs, environmental pollutants, natural compounds, and so on. It binds its ligands with very low affinity, in contrast to what typically hormone receptors do, and accepts a broad spectrum of structurally diverse compounds as ligands, as exemplified here by the small molecules as phenobarbital, up to very large ones, up to 900 Dalton as rifampicin. So it acts as a xenosensor, and with that, it actually induces drug metabolism and excretion of xeno and endobiotics by concomitantly inducing the expression of phase 1 enzymes, cytochrome P450s, of phase 2 conjugating enzymes, and of transporters, especially of ABC efflux transporters. But the function of the receptor is not limited to xenobiotic metabolism. It also has function in basal metabolism of the liver, especially of lipid metabolism and glucose metabolism, and with that is associated to metabolic liver diseases as non-alcoholic fatty liver disease, and it's thought whether that can be used as a therapeutic target there also. But it also has hepatoprotective functions, so it inhibits inflammation, inhibits fibrosis, and the cell-mediated cytotoxicity. But what about further roles in tumors, especially in colon tumor? It has other functions, or in the colon where it's expressed also. It actually is important for the barrier function by upregulating ABCP1 encoded P glycoprotein, which forms a physiological barrier for the uptake of potentially toxic compounds, including all the drugs. And the situation then is a little bit different in colorectal cancer. In these cancer cells, PGP is frequently overexpressed, PXI is frequently overexpressed, resulting in induction of the PGP expression, and this when results, if the drugs are substrates of the PGP, it results in chemoresistance. But that's not all what the PXI is doing in cancer cells. It's not only influencing drug efflux, and thereby coming up with chemoresistance, but also induces proliferation metastasis and inhibits apoptosis, so that we can, in sum up, it induces tumor progression and chemoresistance. With that, and furthermore, it has been shown that recurrence-free survival in CRC patients is better if the peak size expression is low, and it's lower if it's high. So with that, keep in mind, and using as a starting point for that our study, so peak size highly expressed in many colorectal tumors and promotes tumor progression, chemo-resistant CRC, and keep in mind that many antineoplastic drugs demonstrate activation of the receptor. So we came up with our working hypothesis that if chemoresistance was resulting from peak size activation, it may be reverted by concomitant treatment with an antagonist. So we then adapted the following methodological approach. So to analyze the use of peak size antagonists to revert chemoresistance. So first of all, we had to identify peak size expression in CRC cell lines. The problem is that among the very many different CRC cell lines, only a few express high levels of PXR, and we selected then these are RNA data from public available data sources, and then looked for the PXR protein expression in these cells and selected two of these cell lines, the SW403 and the LS174T, as cells where we want to analyze this resistant phenomenon. As a chemotherapeutic, which we want to use to make cells resistant against that, we selected paclitaxel, which is not, I know, a first-line treatment of CRC, but it's the only one of these chemotherapeutics activating PXA where the mechanism has been resolved and is a bona fide PXA agonist. Therefore, we used it in the study. So we then made resistant cells according to protocols I show in the next slide, and analyzed then in a target analysis mechanism of chemoresistant genes by high throughput RT-PCR, analyzed the resistances further for their extent of resistancy, and tried then whether antagonists can, let's say, revert resistant cells back to the controller parental levels. So we followed up 2 strategies to generate resistant cells, and these were first, continuous treatment with increasing concentrations of the drug, starting from 5 nanomolar up to 50 nanomolar over a period of 4 months, and ended up for both cell lines with resistant cells, named here. As a control, we got the control cells were treated with a vehicle for the same time. The second approach was to mimic more or less what happens in clinics. So we pulse treated the cells, and that was only successful for one of these cell lines with consecutive pulses, up to 8 pulses here, over 5 months with short periods of time with 4 micromolar, or even shorter than with 10 micromolar, and ended also here up in resistant cells. So then we had a total of 4 resistant cell models, and we looked whether these cells looked for the extent of resistance they had achieved. And as you can see here easily, compared to the respective control cells, we had a 50 to 20-fold increase in resistance in all our models. Then we were interested in which mechanisms of chemoresistance, MOC, to paclitaxel is behind that, what we saw. And then therefore we selected genes according to the panels of established MOC genes to paclitaxel for a targeted gene expression analysis, and we including, oops, what is that? Oh, animation not working. May you try to, whether you can start it? Okay, I have to recommend. So we're including genes for uptake transporters, which if uptake is reduced, then we have of course resistance. We included genes for efflux transporters. If they are increasingly induced in price, they will also convert resistance. We look for metabolism genes, which for the genes in metabolism paclitaxel as cytochrome P2C8 and 3A4. Looked for potential targets or of the drug, and the drug targets tubulins, and we look there for these tubulins, and looked for an array of apoptotic and anti-apoptotic genes to look whether the balance between apoptosis and survival is altered in the. So now it works. Okay, then quickly going for the genes. So which were in the panel: SLC1B1, FCB1, these metabolism genes, the tubulin beta 3, and a panel of apoptosis, even more. So in a total of 50 or roughly 50 genes we analyzed, and out of them, you can see that in the 4 different models, we saw differential patterns of differential regulated genes. So the common theme was that the ABCB1 gene is always upregulated in all the models, and also the tubulin beta 3 is upregulated. We followed up these 2 genes on the protein levels, and as you can see, exemplary for one of these models here, and so also true for the others, the expression of the big light encoded by ABCB1 is increased, and beta 3 tubulin is also increased. So then we were interested, what is next then? Yes, whether PXA activation is behind that. So for that, we analyzed the expression of all these genes which were differentially expressed here in cells treated with PXA agonists to see whether we have a functional PXA pathway in the cells or with the antagonist SPA70 here, which is a competitive PXA antagonist recently described by others. So what you can see easily only for the ABCB1 and CYP3A4 prototypical PXA target genes, we could see that there was a modulation of PXA activity alters the expression of these genes in the resistant and in parental cells. You can see it here that rifampin treatment, the agonists induce the expression of ABCB1 as well as of 3A4. More importantly, then the antagonist reduces expression, and especially the point is that the increased expression here in the resistant cells is reduced back to basal levels, nearly basal levels, by treating with the antagonist, indicating that the PXR plays a role in the increased expression of 3A4 and ABCB1 in these resistant cells. To follow up further that and to further confirm that PXR plays a role, we knock down PXR in the resistant cells and analyze then what about the alteration of PXR activity. And as you can see here, in control knockdowns, we see that the SPA70, the antagonist treatment, still is reducing ABCB1 expression, as I showed before on the previous slide, but in PXR knockdown, it's no longer possible. So you need the PXR expression activity that the antagonist can work, further confirming that the PXR plays a role in the increased expression in the resistant cells. So as ABCB1, ABCB1 is one of the two genes commonly induced, we thought whether just the ABCB1 expression and activity of the encoded protein, P-glycoprotein, would be enough to explain the resistance in the cells. And for that, we treated resistant cells with the PGP inhibitor tariquidar, and as you see that 0.1 micromolar doses of tariquidar reverted resistance back to the control levels here. So indicating that the resistance is completely dependent on ABCB1 PGP activity. And to make sure that not simply then, when we go further ahead, the antagonist may just simply also inhibit the PGP, the glycoprotein, and by that then resulting in reversal of the resistance. We just checked that 70 concentrations up to 15 micromolar were not able to inhibit or impair PGP transport activity in a transport assay using vesicles with overexpressed MDR1 or P-glycoprotein. We then asked the question, what about the PXR protein itself? And showed that, observed that the RNA expression didn't change in resistant cells compared to respective controls. There was nothing. And it's also true for the two models which were trained by continuous treatment with the drug, that the protein levels also didn't change here, as you see here. But for the pulse-treated cells, we observed that protein levels, irrespective of the fact that the RNA is not increasing, protein levels of these two pulse-treated derived models increased compared to the respective control here. So in that case, explanation is easy, though we have more PXR, therefore explaining easily why the cells express higher levels of the regulated genes. With that, we have to assume that irrespective of the fact that we have same protein levels, the activity in the resistant cells has to be higher. But we have not really followed up that with the end and couldn't really tell what the mechanism behind that is. So then we treated all our models with a constant dose of accelerating dose of the PXR inhibitor, and looked then whether this changes IC50 of paclitaxel mediated cell death. As you can see, we could revert all resistant cells back to the control levels. So inhibition of PXR completely reverses the resistance depending on the ABCB1 PGP expression. To make sure that this is not just a simple compound-specific effect or a mechanistic effect, as we have used here a competitive antagonist, we used further PXR antagonists, which we identified previously. So one was an allosteric non-competitive antagonist, which was pazopanib, coming out from a drug repurpose screening, and another one compound we called compound 73, a mixed competitive, non-competitive passive antagonist, which we identified also previously. And by treating cells, co-treating cells with these antagonists, same doses as with the SPA70, they are not so high affinity to PXR as maybe hormones or the other drugs. we could revert resistance, here the black curve compared with the red and blue, back to the same levels. So to conclude, to sum up what I have reported to you, I hope I've convinced you that I present evidence that the differential expression of MOX genes, AFC1, 3A4, and paclitaxel resistant cells depends on PXR. And that resistance of paclitaxel depends exclusively on the elevated expression of AFCB1 encoding the efflux pump MD on P-glycoprotein, which transports the paclitaxel, pumps it out of the cell. Thus, resistance can be reversed completely by treatment with different PXR antagonists. So this led up to the conclusion that PXR antagonism proved to resensitize colorectal cancer cells to paclitaxel, which may open up new treatment options for the subset of drug-resistant tumors. And this, of course, has to be followed up with more physiological models. With that, I come to an end, just acknowledging the people involved in the work and the funding. And I'm happy to take any questions.
Any question to Dr. Burk?
Thank you, Dr. Burke. That was a really nice presentation. As you had suggested, and I think you know, unfortunately, paclitaxel, the taxanes, aren't used in colorectal cancer clinically, probably because of some of the mechanisms that you described. In fact, actually, our group, many moons ago, at the NCI, did the first phase 1 study looking at a combination of 5-fluorouracil paclitaxel when paclitaxel was just being developed, and it unfortunately just had absolutely no activity. So clearly the taxanes aren't clinically relevant in colon cancer, but actually one drug you might want to think about testing in your model system is the BRAF inhibitor, encorafenib.
Encorafenib, yeah.
The reason is because that drug, that oral BRAF inhibitor, is now currently approved for use in the treatment of metastatic BRAF colorectal cancer. And if in fact in your PXR resistant system you see resistance to encorafenib, then I think actually your model systems would be quite relevant.
Yeah, that's a good suggestion, and also that would be interesting to establish encorafenib resistant cells, because the drug as a tyrosine kinase inhibitor is also has been shown to be a PXR activating drug, but that may not just be by ligand binding, but it also may by just influencing the modulating the phosphorylation status of the receptor. But no one has tested, but that would be a possibility. Yeah, that's a great idea.
It's a very good suggestion, yeah. Any further question? If not, thanks, Dr. Burke.
Thank you.
Yeah. Next speaker, I would like to introduce Dr. Elbert Chu, to give the presentation about immunotherapy in colon cancer. And Dr. Chu is currently Albert Einstein Cancer Center Director and University of Albert Einstein Vice Chancellor. He received MD from Brown University and oncology training at the NIH, United States. And after that, he moved to Yale to start his career, and then go to the University of Pittsburgh for a while. Several years ago, he moved to Albert Einstein, and at this moment, he oversees overall immuno-oncology as well as all the cancer-related activities of Albert Einstein. So please, Dr. Chu.
Thank you, Dr. Yan, for that nice introduction, and thank you and Dr. Lin for inviting me to come and present at this symposium. And so what I'd like to do is to just provide an update on where we are with respect to the immunotherapy of colorectal cancer. And just by way of background, colorectal cancer unfortunately remains a major public health problem, both in the United States and globally. So in the United States, there are about 150,000 new cases of colon cancer diagnosed, and that's associated with about 52,000 deaths. Worldwide, 1.2 million cases of colorectal cancer diagnosed each year and associated with about 600,000 deaths. Unfortunately, even though we've made tremendous advances, and I'll show with you kind of our armamentarium for treating colon cancer, when colon cancer is diagnosed in the metastatic disease setting, it still is associated with extremely poor prognosis, and 5-year survival rates are still less than 10%. And that number actually hasn't changed even going back to when I was a medical oncology fellow at the National Cancer Institute back in the mid-1980s, so eons ago. And so there really still is significant unmet need for new treatment strategies in the chemo-refractory disease setting. So for about 40 plus years, we had only one drug, and that was the golden oldie 5-fluorouracil of fluoropyrimidine. And then starting in 1996, with the approval of the topoisomerase inhibitor, irinotecan, there are now 14 drugs that are currently approved for use in the treatment of metastatic colorectal cancer. So this includes cytotoxic chemotherapy, biologic targeted agents. And then in 2016, we finally got into the game in terms of immune checkpoint inhibitors. So pembrolizumab, nivolumab, ipilimumab were approved. And then I just recently mentioned encorafenib in combination with the anti-EGFR antibody cetuximab was approved to treat BRAF metastatic disease. And so this is kind of the pie chart of potential actionable targets as of 2023. And for today's discussion, we're going to focus actually on MSI high, so that's microsatellite instability high, or tumor mutational burden high metastatic colorectal cancer. But as you can see, they represent really only very small slivers of this pie. So about 95% of metastatic colorectal cancer is mismatch repair proficient. Only about 5% of metastatic colon cancer is what's called MSI high or defective mismatch repair. MSS, metastatic colorectal cancer, is considered to be a cold tumor and immune excluded. And I'll show you kind of the practice-changing clinical study that we were part of, along with the folks at Hopkins. Single-agent PD-L1 or PD-1 inhibitors have essentially no clinical activity in the setting of microsatellite stable metastatic colorectal cancer. So I think some of you are probably familiar with the fact that melanoma and lung cancer are felt to be so-called hot tumors, inflamed tumors, and exquisitely sensitive to immune checkpoint inhibitor therapy. And this slide shows kind of the tumor mutational burden. In fact, mismatch repair defective colon cancers has significantly higher amounts of mutations per tumor. And as you can see, this is in sharp contrast to mismatch repair proficient colon cancers. So this is why actually you can see this sets up a scenario where the tumors are going to be more sensitive to immunotherapy, immune checkpoint therapy, as compared to mismatch repair proficient or MSS disease. This slide just kind of highlights the scorecard right now of the immune checkpoint inhibitors. So there are actually 5 molecules that target the PD-1 receptor located on the T cell. There are 3 antibodies that target the PD-L1 that comes from the tumor cell. And there are 2 antibodies that target the CTLA-4 antigen expressed on the T cell. And again, just to refresh your memory, so molecules, antibodies that target the PD-1 signaling pathway, either the PD-1 receptor itself or the PD-ligand-1, reverse T cell exhaustion, and in so doing, stimulate T cell function. And so by inhibiting the PD-1 signaling pathway, you can significantly boost T cell immunity and enhance anti-tumor efficacy. So this is the landmark paper, really the practice-changing clinical study that was led by investigators at Johns Hopkins, Yung Lee and Louis Diaz, and our group at Pittsburgh actually also was very actively involved in this clinical study that was published in New England Journal of 2016, and actually Jung presented this in a plenary session at the American Society of Clinical Oncology annual meeting. So that's the big clinical oncology meeting in 2016. So the study design was pretty straightforward. There were 3 different cohorts, 2 cohorts for colorectal cancer, 1 cohort defective in mismatch repair, and 1 was proficient, MSS. And then there was a non-colorectal cancer group that was defective in mismatch repair. Okay, so the anti-PD-1 antibody pembrolizumab was given using weight-based dosing, 10 milligrams per kilogram every 2 weeks. We now actually just give fixed dosing. And so what was really impressive about this study, right off the bat, was in patients with mismatch repair defective disease, 28 patients, Objective response rate, 57%. No response in those tumors that were mismatch repair proficient. And the overall disease control rate, 90%. If you look at the progression-free survival, not reached in the patients that were reported, whereas in the mismatch repair proficient, the median PFS was 2.3 months. And that was really highly statistically significant. And if you look at the initial overall survival curves, again, in the mismatch repair defective tumors, the median overall survival had not been reached and significantly greater than in those who had mismatch repair proficient disease. So the conclusions from this study, really this landmark study, was this is the first clinical study, truly practice-changing, to use a tumor's molecular genetics, in this case MSI, mismatch repair, to guide immunotherapy for patients with metastatic colorectal cancer. And that MSI status predicted clinical benefit of inhibiting the PD-1 signaling pathway, and in this case, to pembrolizumab therapy. But this study has now been confirmed using nivolumab therapy. One can actually assess MSI status using either immunohistochemistry, right, looking at protein expression, or PCR-based methodologies. And interestingly, mismatch repair defects are present in about 5% not only of metastatic colorectal cancer, but in endometrial cancer, stomach cancer, cholangiocarcinoma, pancreas, prostate, and brain. Okay, so now fast forward to 2020, my good friend Thierry André in France actually was the principal investigator of the Keynote 177 study, which also is practice-changing. And this study actually looked at the anti-PD-1 antibody pembrolizumab versus standard cytotoxic chemotherapy plus biologic therapies in patients with MSI high, mismatch repair defective metastatic colorectal cancer. Study design was very simple. If patients actually had MSI high or defective mismatch repair disease, they were randomized to receive either pembrolizumab alone, and now rather than weight-based dosing, they used a fixed dose of 200 milligrams every 3 weeks. So one of the advantages of antibodies in general, but all of the immune checkpoint molecules, they have long half-lives on the order of 14 to 21 days. And this was versus investigators' choice chemotherapy of either what's called FOLFOX or FOLFIRI, plus or minus the anti-VEGF antibody cetuximab or the anti-EGFR antibody cetuximab. There were two main endpoints, progression-free survival and overall survival, and a secondary endpoint of overall response rate. And what was really very striking and again really impressive was that single-agent pembrolizumab led to a significantly improved progression-free survival and reduced the risk of disease progression by 60%. And as you can see, highly statistically significant. If one looks at the median progression-free survival, it's doubled from 8.2 months to 16.5 months. If you look at the response rate, also quite impressive, a little bit higher with pembrolizumab versus chemotherapy, but I'll just focus here on complete response. So with respect to cytotoxic chemotherapy and biologic agents, it's unusual for us to see a complete response. And in this study, it was about 4%. And so it was about 2.5-fold increased complete response rate with pembrolizumab monotherapy. So that actually was really very, very impressive. If you look here at the duration of response, it's also significantly increased in patients who were randomized to receive pembrolizumab. And if you look at the 24-month response duration, significantly improved. If you look at the adverse events, significantly greater with cytotoxic chemotherapy, more than threefold. It's 22% with pembrolizumab monotherapy to 66%. So this is grade 3, grade 4 toxicity. So clearly, the chemotherapy arm much more toxic to patients. Not surprisingly, in patients receiving pembrolizumab, they did experience immune-mediated adverse events and infusion reactions. However, for the most part, really pretty well tolerated. So the conclusions of this landmark Keynote 177 study is that single-agent pembrolizumab provided clinically meaningful and highly statistically significant improvement in PFS versus chemotherapy. And again, the median PFS was doubled, and the 24-month PFS rate significantly improved. Responses more durable with single-agent pembrolizumab with prolonged duration of response. Safety profile also favored the pembrolizumab arm. Because of this study, single-agent pembrolizumab was approved by the U.S. Food and Drug Administration, as well as kind of the European equivalent, the EMA, for the first-line therapy of MSI-high or defective mismatch repair metastatic colorectal cancer. And so now single-agent pembrolizumab, but also the other anti-PD-1 antibody, nivolumab, is considered, at least in the United States, standard of care as first-line therapy in patients with MSI-high or defective mismatch repair metastatic colorectal cancer. So again, just to go back to this slide of the immune checkpoint inhibitors, and the last one we're going to talk about is dostarlimab, which was originally approved in the United States for the treatment of MSI-high or defective mismatch repair endometrial cancer. So dostarlimab is a humanized IgG4 antibody, binds to and inhibits the PD-1 receptor on the T cell. This inhibits the interaction of the PD-L1 and PD-L2 ligands with the cognate PD-1 receptor. And again, inhibition of the signaling pathway restores T cell immune function, including T cell activation and proliferation. So this was, again, a practice-changing clinical study that Andrea Sursek and her colleagues at the Memorial Sloan Kettering Cancer Institute in New York presented at the 2022 ASCO annual meeting. Okay. So this is looking at patients with mismatch repair deficient rectal cancer. So rectal cancer is just a very small subset of colorectal cancer. Approximately 5 to 10% of patients with rectal cancer are mismatch repair deficient. So kind of on the same order of magnitude as metastatic colorectal cancer. In general, these patients are resistant to chemotherapy. And I've already mentioned that checkpoint blockade highly effective in the setting of metastatic mismatch repair defect. So this was the design of the study. Dostarlimab given 500 milligrams every three weeks, and patients underwent both imaging as well as endoscopic evaluation. The patients included in the study were stage 2 and stage 3 mismatch repair defective tumors. And the primary objective was overall response rate, secondary objective, safety and tolerability. And then in terms of looking at the response, patients received rectal MRI as well as endoscopic exam. And so this just shows the demographics of the patients, and the key is that they were high-risk locally advanced rectal cancer with T3, T4, so that's kind of like big, bulky disease, as well as almost all the patients had node-positive disease. So this is a very high-risk patient subset. Before this study, we typically would treat patients with a combination of systemic chemotherapy and radiation therapy, and then subject patients to surgery, followed by more chemotherapy, okay? And then these patients also were analyzed for their tumor mutational burden, and it was relatively high. What was really dramatic, the first 14 patients that Andrea and her colleagues presented, complete clinical response. Overall response rate, 100%. I mean, I have to say, I've been in the colorectal cancer field since the 1980s. We've never seen any kind of result like this. It was really kind of mind-blowing. This shows the duration of response, which also now it's 2 years, really all holds, okay? So the key observations, 100% clinical complete response, no grade 3, grade 4 toxicity. No patients have required chemotherapy, radiation therapy, or surgery, which typically would be the approach to these patients with locally advanced rectal cancer. To date, and even this now goes up to 2020, no disease recurrence observed during the follow-up period. Of course, obviously, longer follow-up is required, but it's really remarkable how well these patients have done. So this data provides the framework now for what's called immunoablative therapies in the absence of systemic chemotherapy, radiation therapy, and surgery, and really does highlight the the real importance of biomarker-driven therapy. In this case, MSI high status, defective mismatch repair, tumor mutational burden, okay? And this has the potential to be translated rapidly into areas around the world without access to modern chemotherapy, radiation therapy, surgery. So this really, again, is a truly practice-changing clinical study. And this study was published last June 2022 in the New England Journal of Medicine. So to conclude, right, in terms of immunotherapy of colorectal cancer, immunotherapy is a reality in patients with MSI high, defective mismatch repair colorectal cancer. In the frontline setting for MSI high metastatic colorectal cancer, it's the standard of care. And you can use either nivolumab pembrolizumab monotherapy, or if the patient can tolerate it, one can consider the combination of two immune checkpoint inhibitors, nivolumab plus ipilimumab. And with respect to locally advanced early stage MSI high or defective mismatch repair rectal cancer, dostarlimab is considered the standard of care. Now, what about MSS metastatic colorectal cancer? So that's unfortunately a very different story. And you've already heard a little bit about this. There are just a number of mechanisms of resistance to cancer immunotherapy in general, and certainly to metastatic colorectal cancer. So you have tumor intrinsic factors, factors that are specific to the tumor microenvironment, and you have host-related factors. And you've already heard a little bit of almost about all of them from each of our speakers today. And this just kind of goes into more detail about the mechanisms of resistance. So as much as we tout the real importance and the breakthrough, the great developments of immune checkpoint therapy, we're still not curing the vast majority of those patients, except maybe for locally advanced rectal cancer, okay? And unfortunately, all of these resistance mechanisms are at play. And so there have been a number of approaches that have been taken to try to enhance immunotherapy in the setting of MSS, mismatch repair proficient metastatic colorectal cancer. So this slide just kind of is a nice illustration. And here I've just kind of summarized it in text form. So there really have been intense efforts, and our lab and our clinical group have really tried to develop novel immunotherapy combination approaches for MSS metastatic colorectal cancer. Again, this makes up 90 to 95% of all the metastatic colorectal cancer that we treat in the clinic. So combination of different immune checkpoint inhibitors, combining IO with targeted agents that hit key signaling pathways, IO plus chemotherapy, IO plus radiation therapy. This is a very active area. The bottom line is all of the various studies that have been conducted to date, negative. And in fact, there have been 5 randomized clinical trials that all in early phase 1 and even phase 2 settings were really very positive and very promising. But then unfortunately, once they got to either the larger randomized phase 2 or larger randomized phase 3 setting, all negative to date. So there still is a lot we need to learn, and there still are a lot more clinical studies that we need to do, but we need to be now, I think, much more thoughtful. Unfortunately, all of the major IO companies in the field have just been kind of IO plus X, IO plus Y, IO plus Z, and I'm not sure it's really been as thoughtful as it could be. Now, just in the last minute or so, what I thought I would just share with you is one of our senior investigators at the Montefiore Einstein Cancer Center, Professor Yi-Ching Wang. So Yi-Ching was actually a postdoc with Jim Allison when Dr. Allison was at the Rockefeller and developed his groundbreaking research. Yi-Ching himself has now identified at least 5 different immune checkpoint pathways. And the most recent one he's identified is this immunosuppressive KIR2DL5 PVR, poliovirus receptor, which is present on the tumor cell. And actually by inhibiting this PVR KIR2DL5 pathway with an antibody, an anti-KIR2DL5 antibody, he's actually able to restore, and this is actually on the NK natural killer cell, he's actually able to restore NK cell-mediated anti-tumor immunity And in studies, he's shown that actually he can reverse resistance to PD-1 inhibitors, CTLA-4 inhibitors, and also TIGIT inhibitors, which is another immune checkpoint pathway. And a lot of these studies have actually been done in a wide range of human cancers, but because of my own interest in colorectal cancer, he's also shown that colorectal cancer, it may be a potential option. And we're actually hoping down the road to be able to do early phase clinical trials with this novel immune checkpoint antibody, but immune checkpoint on natural killer cells. So with that, I thank you for your attention, and I'm happy to answer any questions.
Any question? Yeah, there.
First, a simple question. Am I correct in thinking that the patients who had excellent response had the Lynch syndrome most likely?
No.
Or is that different?
No, it's different. So you're actually, patients who have the Lynch syndrome would respond. So actually, as it turns out, the majority of patients with metastatic colorectal cancer, so they're MSI high, they're silencing of the mismatch repair genes, but it's actually because of methylation. It's actually not because of an underlying genetic mutation, as you see in the Lynch syndrome.
So those were not the ones who had the successful results that you showed at the beginning, in other words?
So those patients actually, so they don't express the mismatch repair proteins, but
Right.
it's not because of genetic mutations, it's because of silencing.
I see, I see. And so when you were talking about the various other patients with other disorders beside colorectal cancers, have there been studies in those populations to show similar success, or has that not been done?
Yeah, so in fact, for endometrial cancer, that's why
you mentioned
dostarlimab
that,
was
right.
actually approved. And actually for cholangiocarcinoma, gastric cancer, in the setting of MSI high, mismatch repair defects, the immune checkpoint molecules actually are now approved for use.
Okay. Thanks a lot.
Yeah, next question.
Hi, Dr. Cheng. Very nice work. I'm Du Zhu from Fudan University. I have one question about the metastatic colorectal cancer. Do you think the tumor resistance in the MSI high is due to the tumor microenvironment itself or the tumor cell? Do you think the metastatic colorectal cancer, whether the combination could works better in the metastatic colorectal cancer?
Yeah, no, it's a great question. The simple answer is we don't know. It's complicated, and the problem is, probably every patient has distinct resistance mechanisms, so that makes it even more challenging.
Indeed, but it's very interesting to know that most of the combination trials all failed in the last 7 years. So do you think there must be some fundamental mechanism within the immunity or in the tumor cell that's driving the immune resistance?
Yeah, and as you can imagine, a lot of translational biomarker studies have been done. There hasn't been that one kind of common mechanism that says, oh, this is why they're not responding.
Okay.
So I think it remains a very challenging area, truthfully, to figure out how to move forward with these molecules, at least for colorectal cancer.
Great. And my second question is, I think my previous work, we also find that targeted Wnt signaling within the tumor can change the expression of the CD155, and we published that before. And very good to know that you found that blocking this interaction it could also boost the immune response in CRC.
Yeah, and as you probably know, a lot of folks have tried to kind of use the Wnt signaling pathway, inhibit it in combination with IO to give it a boost. Again, so far those studies haven't been positive. But
hasn't not been positive. You mean there's no positive signal reported yet about the Wnt inhibitor?
Right.
Okay.
So that's why this newer NK pathway will be very interesting to see.
Okay. Thank you.
Yeah, Dr. Chu, one question. Did anyone look into the tumor mutation burden in the proficient patients?
Yeah, so it's very low.
Very low.
Yeah.
Yeah.
So it's less than, it's like 5 to 10.
Yeah. So that's not hot. Yeah. Any further question? If not, thanks, Dr. Chiu. Yeah. Last but not least, our last speaker for this session is Dr. Yi-Ching Wang. Dr. Wang is director of the Department of Pharmacology, National Cheng University, Tainan, Taiwan, and also chair professor of the Institute of the Basic Medical Science of College of Medicine. She received a PhD from Michigan State University, and then continued to be very productive in publication, high impact journal, and received lots of award in Taiwan. And his research focus is continued focus on molecular mechanism in DNA methylation. And today, her topic is target protumor secreting factors and the transcription factors. Please, yeah.
Thank you, Dr. Yuan, for the kind introduction and also for the invitation for me to speak at WCP to share our recent work on the cancer immunotherapy. And I'm going to divide my talk into two sections today. First one is about targeting protumor secretion factor for cancer immunotherapy, and the second one is using the post-translational modification of PD-1 for predicting cancer patient response for immunotherapy. So first, about the protumor secretion factor, they are existing together with cytokine, chemokine in sensitive tumor as well as resistant tumor to remodeling the tumor microenvironment. And since they are expressed abundantly in the tumor microenvironment, so if we can generate a neutralizing antibody against those protumor secretion factor, we may have an opportunity for treat cancer patients. So my lab has a long-term interest on the protumor secretion factors because we have studied the protumor secretion factor mediated by Rep exocytosis. And in fact, the two proteins I talked today are cargo of Rep exocytosis. But today, my talk will focus on more the therapeutic and the biomarker value of these two proteins. And the first one is CHI3L1. It stands for the kinase 3-like 1, and I will call it C protein in my following talk. And it is a protumor secretion glycoprotein which can be secreted by the fibroblasts, macrophages, T cells, as well as advanced tumor cells, and lead to the promoting of the tumor growth as well as the M2 polarization and the protumor T helper 2 response. And we have evaluated further about the expression level of the intratumor 3L1 protein. This can be increased in the advanced cancer patients. And importantly, the high plasma level of the C protein correlate well with the poor survival in the lung, pancreatic, and colorectal cancers. And for proof of concept, we have generated polyclonal antibody, and the polyclonal antibody against C protein can reduce the pancreatic cancer tumor growth as well as prolong the survival of treated mice. And the mechanism of action is that the secreted protumor C protein can bind on the receptor on the tumor cell to promote the tumor growth and metastasis through the signaling pathway shown here. And the protumor secretion factor C protein could also act on the immune cells to foster an immunosuppressive tumor microenvironment. And the neutralized antibody could reverse those protumor effects induced by the C protein. So to further translate our neutralized antibody, we have generated fully human monoclonal antibody against the C protein. And showing here the circulating plasma level of C protein and the intratumor C protein of the 4 of the antibody leads we have now compared to the IgG group. And since they are humanized monoclonal antibody. So we use humanized mice for the anti-cancer effects. And to study further about the C protein neutralization effect of the tumor microenvironment, we collect the endpoint tumor and perform the multicolor immunofluorescence IHC to check the tumor-associated macrophage profiling in the endpoint tumor. And on the left, you could see, I would like to draw your attention about the anti-tumor M1 macrophages, especially the distribution of these anti-tumor macrophages. On your left, you could see those anti-tumor macrophages can only localize in the peritumor regions. However, upon our C protein neutralized antibody, the anti-tumor M1 macrophages can now infiltrate to the core region of the tumor. And similarly, our neutralized antibody could also increase the infiltration of the anti-tumor cytotoxic CD8s, indicated that our neutralized antibody could reverse the anti-tumor into the anti-tumor immune microenvironment. And importantly, our neutralized antibody also show the anti-fibrosis effect. And showing you here the fibrosis staining evidenced by the alpha SMA and the collagen staining. And you could see our neutralized antibody could reduce the tumor fibrosis in the pancreatic cancer as well as the lung cancer model in the humanized mice. So luckily, one of our antibody clone can cross-react with mouse. So we could use syngeneric tumor competent, immune competent mice for the orthotopy pancreatic cancer model here. And we first examined the dose-dependent manner of our neutralized antibody, as well as in combination with the gemcitabine, which is the current chemo drug for pancreatic cancer. And as you can see from the image here, the combination group of our monoclonal antibody with gemcitabine show a good reduced effect of the tumor signal and the tumor weight without changing the mouse body weight. And importantly, our neutralized antibody combination with gemcitabine could increase the anti-tumor immune cell, including the M1 macrophages, as well as the CD8 T cells. And we also do the fibrosis study. You could see the IgG and the chemo group show a severe tumor fibrosis. However, our monoclonal antibody together with gemcitabine group largely reduced the tumor fibrosis. So our neutralized antibody not only reduce the tumor growth, metastasis, but also reverse the immune microenvironment, as well as reduce the tumor fibrosis. And I would like to just add one point here. Please see the right-hand panel. Actually, we collect 11 lung cancer patients received the immune checkpoint inhibitor treatment. And we measure the plasma level of the C protein. You could see for those non-responder patients, the plasma level of C protein is largely increased compared to the responder. So this gives us the rationale for our neutralized antibody of C protein could be a potential plasma biomarker guide immunotherapy. So in the future, we could select those patients who has a high level of plasma level of C protein. Those patients were beneficial with our neutralized antibody against C protein. And by measuring the plasma level of C protein, we could also monitor the treatment response of the patients. So now I'm going to move to the second session of my talk, that is PD-1 inhibitory receptor. And as you know that PD-1 inhibitory receptor is required to proper activation of T cells and upon antigen stimulations. And however, in the tumor microenvironment, the PD-1 can conjugate with PD-L1 in the cancer cell, and this will lead to the T cell tolerance. And there are a lot of studies investigating the PD-1 transcription regulation. However, the post-translational regulation and upstream signal of PD-1 in T cell remain largely unknown. So my talk today going to share with you our recent study on 2 PTMs. They are first phosphorylation and secondly the ubiquitination. Before I go into the detail, I would like to talk about IL-6 JAK pathway in the tumor microenvironment. My lab previously have shown that tumor microenvironmental IL-6 can bind to the receptor on the CD8 T cell, and this will lead to the STAT3 transcription activation of the PD-1 gene, and this will lead to the upregulation of PD-1, therefore resulting in exhaustion T cells. And other studies have shown that IL-6 could activate JAK1 kinase and to phosphorylate PD-L1 in the cancer cells. So together we hypothesized that maybe the IL-6 JAK kinase could also phosphorylate PD-1 in the T cells. So this is our hypothesis. Actually, this is a collaborated work among my grad students. And for the M1, we would like to know whether IL-6 can phosphorylate, the IL-6 JAK pathway could phosphorylate the PD-1 in the T cells. Since there are two major JAK kinase, JAK1 and JAK2, so we first performed the dataset analysis, and we found that the JAK2 kinase correlate better with PD-1 expression compared to the JAK1. So we focus on the JAK2 kinase, and we add the recombinant IL-6, which can quickly induce the phosphorylation of the JAK2 as well as phosphorylation of the PD-1. And such IL-6 induced phosphorylation of JAK2 and the PD-1 is largely attenuated by adding the JAK2 inhibitor as well as knocking down of the JAK2 in the T cells. So we further study the cellular distribution of the PD-1 and the JAK2, and the merged panel showing you the colocalization of phospho-PD-1 and the phospho-JAK2. And interestingly, using the IP and the reverse IP, we could prove that in addition, adding the recombinant IL-6 could induce the protein-protein interaction between JAK2 and PD-1 in T cells. Now come to our second aim. We would like to know what is the phosphorylation site on the PD-1 by the JAK2. So we performed the software prediction, and we found that the tyrosine 223 and 24A in the intracellular domain of the C-terminal region of PD-1 was suggested as a phosphorylation site target by JAK2. So we made a site-direct mutagenesis. And interestingly, the phosphomutant indeed reduced the phosphorylation level of the PD-1. And interestingly, the total level of PD-1 was also decreased. So suggesting that phosphomutant may reduce the protein stability of PD-1 in T cells. So we performed cyclohexamide chest assay to measure the protein half-life of the wild type versus phosphomutant PD-1. And you can see here, the phosphomutant PD-1 indeed reduced the protein stability compared to the wild type PD-1. So the phosphomutant could reduce protein stability of the PD-1. In other words, phosphorylation of PD-1 could enhance the protein stability. And therefore, we further do the ubiquitination blot analysis. You could see the phosphomutant of PD-1 indeed increased the ubiquitination on the phosphor mutant. So this will lead us to do the second PTM, that is ubiquitination. So far, there are only 4 E3 ligases reported to be the ubiquitination control to degrade the PD-1 in T cells. However, there's no report on the deubiquitination enzyme for the PD-1. So in collaboration with Dr. Jianzhong Hong in the Life Science College in our National Cheng University, we went further to do the ubiquitination and deubiquitination analysis. And again, we performed the database analysis, and we found that the PD-1 expression together with other co-inhibitory receptor, they are all upregulated in a non-responder of PD-1 blockade therapy. And importantly, those USP, the full names ubiquitin-specific peptides, many of the USP were also upregulated together with PD-1 gene. So we set up the screen model using different knockdown for different important USP. And you can see here the USP24, when we knock down the USP24, the PD-1 level dramatically decreased, suggesting that USP24 may be important to deubiquitinate the PD-1. So we hypothesized that USP24 may involve in the T cell functionality control. So we first overexpress the, we first knock down the USP24 or overexpress USP24. As you can see from here, the expression level of USP24 positively correlate with the PD-1 expression. And the cyclohexamide chest assay showing you the T cell knocking down with USP24 could reduce the PD-1 protein half-life. And this positive correlation between USP24 and PD-1 indicate USP24 can stabilize the PD-1. And since USP24 can remove the ubiquitination of the target protein, so we went further to study the ubiquitination of the PD-1 upon USP knockdown. As you can see from here, USP knockdown indeed can increase the ubiquitination of the PD-1. Why? Overexpression of the wild-type USP24, you could see the down level of the ubiquitination of the PD-1, but not the USP24 catalytic mutant, indicate that USP24 can stabilize PD-1 by the deubiquitination catalytic activity in the T cells. So we went ahead to do the protein-protein interaction using the IP and the reverse IP in the jacket T cells, as well as the PBMC, peripheral blood monocyte. And you can see the protein interaction could be found in both USP24 and PD-1 in both jacket T and the PBMC. And remember, I told you that IL-6 can increase the protein stability and expression level of the PD-1, and such IL-6 induced PD-1 expression increase could be attenuated by knocking down of USP24. So indicate that the IL-6 can trigger the USP-mediated PD-1 deubiquitination. So our study so far telling you that IL-6 can trigger JAK2 to phosphorylate PD-1 together with USP deubiquitination of PD-1. This would prolong the PD-1 protein stability, and the overpresentation of the PD-1 on the T cell membrane will lead to the T cell exhaustion. So we think perhaps when we use the neutralized antibody of IL-6, can we reverse the T cell exhaustion phenotypes? So this is what we do. We do the orthotopy lung model in the immunocompetent mice using the monotreatment of IL-6 or together with IL-6 and CTLA-4 combination group. You could see the orange bar here, the combination group reduced the tumor growth as well as prolong the survival of the treated mice. So we collect the endpoint tumor to study the immune profile, especially the infiltrate CD8 T of those control tumor and the antibody-treated tumors. Again, we use a multicolor immunofluorescence IHC. I would like to draw your attention to the left-hand panel first. We stain the infiltrated CD8 T with phosphor PD-1 in red, and also the LAG3, another inhibitory receptor in blue. And you could see in the large tumor of IgG control, you could see a lot of infiltration of the exhaustion T cell here. In contrast, upon anti-IL-6 treatment, you could see a lot of green signal represent active T cell infiltration. And we also do the analysis for the USP24 expression, showing you in the blue color here. And again, the IgG control tumor show a lot of infiltration of the exhaustion T stained by the USP positive, PD-1 positive, and CD8 T. And this study suggests that neutralizing IL-6 can indeed attenuate both JAK2 phosphorylation PD-1 as well as the USP24 deubiquination of PD-1 axis. So how about the immune profile, especially CD8 T in the lung cancer patients? So we the left-hand panel showing you the tumor obtained from the early stage lung cancer patients. You could see the infiltrated CD8 T are mostly active CD8 T. However, in the tumor from the late stage lung cancer patient on the right-hand side, you could see the exhaustion T indicated by phospho PD-1 LAG3, CD8 T was largely increased. And for those patients with high level of exhaustion T, show poor overall survival and the progression-free survival. And how about the USP24? We now recruit 90 lung cancer patients, and we do the multicolor with 4-color stain and USP24 stain with a green color. You could see the 4 positive exhaustion T was largely infiltrated in the late-stage tumor patients. And interestingly, those patients with high infiltration of exhaustion T also show poor overall survival. So indicated that the PD-1 PTM biomarker could predict the patient survival if the patient have a high level of phospho PD-1 or USP positive infiltrate CD8 T. And actually, I would like to show you one last data which was sent by my student last night. Okay, we are all very excited about it. So I want to show you here. Actually, this data is done in the PBMC from the patient received the ICI, and my student do the MRI extraction examination for USP24, and the A panel showing you the basal level of USP24. You could see the basal level of USP24 increase in those non-responder patients. And for the patient who are non-responder, after the treatment, the USP24 messenger RNA level in the PBMC could further upregulated. And interestingly, the USP24 messenger RNA level positive correlate with the exhaustion T cell profile in the PBMC exam by flow cytometry. So this data is quite exciting because we could now use the PBMC a level of exhaustion T, as well as those USP, or we are now doing the JAK2 messenger RNA examination. And those could serve as a broad biomarker to guide immunotherapy. So I've shown you the new data about IL-6 JAK2 USP axis to prolong the protein stability of the PD-1, therefore resulting in T-cell dysfunction. And by targeting the IL-6 and perhaps also the USP signaling, which we are working on it, we could have a potential treatment strategy for cancer patients. So finally, I would like to acknowledge my collaborator at NCKU, Dr. Jianzhong Hong and Dr. Zhipeng Zhang, for their help on the PTM and the immunological study. And also Dr. Wuzhou Su and Dr. Yuansheng Shen for providing us the patient samples. And also Ruihua Chen and Lijong Xu and Xuefeng Ran from Academic Syndicate and National Taiwan University for helpful suggestion. And although they also help us on the single cell analysis, which I don't have time to share with you today. And most importantly, I thank my my postdoc and my students. Without their passion in the science, we could not do the study, the molecular biology study in the T cell. So I would like to also thank the funding agents in Taiwan, and also thanks for your attention.
Yeah. Thank you, Dr. Wang. Very outstanding talk. Any questions from floor? Maybe I ask one about your anti-fibrosis. You did not. I know there's two story overlap a little bit, but you not look for detailed fibrosis part like a TGF-beta, etc., or stemnant. Could you elaborate a little bit more orally? Yeah.
Okay, thanks, Professor Yang. We actually have checked the TGF-beta signal upon our C protein neutralized antibody treatment, or also adding the recombinant protein of C protein. And TGF-beta signal is not involved in the fibrosis issue we talk. But we now have found that the C protein can promote the macrophage transdifferentiation to the fibroblasts. So this is one point that we further pursue to study why the C protein can induce transdifferentiation of the tumor association macrophage to the CAF, cancer association fibroblast. Therefore, fibrosis.
Thank you. Yeah. Please.
Hi, Professor Wang. Very interesting work. I have one question for you. For the part one of your work, did you compare the response of different cancer in different stage, response to the protein, the C protein antibody, because the C protein secreted from the T cells. So during the different stage of the cancer, perhaps the T cells presented a different function or phenotype.
Okay, thanks for your question. Actually, C protein can be secreted not only T cell, but mostly macrophages, and sometimes in the late stage of cancer epithelial cells. So we did check the C protein level in the intratumor region, as well as the circulation blood level, and the C protein level could indeed increase upon patient progress.
So which means the C protein antibody specifically effect on the late stage of the cancer, right?
Right, because most of the patients who receive the chemo or IO, they are mostly in the late stage of the diseases.
Okay, I understand. Thank you.
I think you are thinking about prevention. If we can give the patient early about our neutralized antibody. We have not done that. We are thinking about it. Yeah.
Okay, thank you.
Thank you.
Or maybe vaccine.
Yeah, vaccine, yes. Okay.
Yeah. Any further questions? If not, thanks, Dr.
There's
oh,
one
oh,
more
yeah, there's
question.
one. Oh, okay. Sorry, I missed that. Yeah.
Thank you, Dr. Wang, for your beautiful presentation. And I have a question about IL-6. You show that IL-6 have the direct impact to the CD8 T cells by promoting its exhaustion. But I'm just wondering that if any other immunocyte will have the role in this process.
Yes, actually, maybe I emphasize too much about IL-6, but I believe other protumor cytokine may play roles, but we don't have the direct evidence now. But IL-6 is the main focus of this study, and indeed IL-6 can, actually IL-6 indeed is a polytrophic cytokine, and in our setting, the IL-6 in the progressed tumor is kind of chronic expressed in the progressed tumor. So we think the IL-6 in the progressed tumor, there are a lot of IL-6 present, and this will trigger the JAK2 phosphorylation as well as the USP deregulation. This could be, this should be, I should say, this situation should be in the progressed tumor. And this will lead to further prolonged expression of the PD-1 on the T cell. Therefore, sustainable PD-1 would conjugate with PD-L1 in the cancer cell. This will lead to T cell exhaustion. But we cannot rule out other important cytokines, which we have not checked yet.
Okay, thank you.
Thank you.
Any further questions? Okay, if not, thanks, Dr. Wang. Thank you.
Thank you.
Yeah. Close up this session, and thanks for your attendance. Appreciate it. Bye.